all those ICU patients you take care of up in the ICUs, patients that are that sick are not generally candidates for regular elective surgeries. So most of the surgeries that you do are going to be on like somewhat healthy patients. So you're not going to be slinging norepi and vaso and epi all the time like you do in the ICU. So your ICU training for those complex patients and those vasopressors is super, super critical. So the more of that you can do, the more code team you can do, the better off you're going to be. Complex patients, your ICU training, a big part of it that translates over to anesthesia is taking care of complex patients with comorbidities. Because in anesthesia, we need to know how each of those comorbidities is going to affect our anesthetic. And we want to be accustomed and tuned into and not intimidated by complex patients when we get them on the operating table in anesthesia.
Hello, future CRNA. Welcome to CRNA School Prep Academy podcast. I have a very special episode lined up for you today, and it is part of our guest host series where I am bringing current SRNAs on the show for you as a guest host on the CSBA podcast. And my thought process behind doing this is I wanted you to hear from current students, a variety of current students who are at different stages of their CRNA journey, and really allow you to kind of step into their world and hear them talk about what it's like to be a current student dealing with things like difficult preceptors or different anesthesia topics, clinical topics, maybe even things like time management, stress management, things like that. I think these episodes are going to be gold, and I hope you enjoy as much as I always do hearing from current students. I know for a fact that the reason why CRNA School Prep Academy is where it is today, and the reason why I have learned so much is from diving all in, listening to current students along with CRNAs share a wealth of information and really kind of taking all of that information and kind of compiling it into kind of the system that we have created today. And I know that you're doing the same thing by tuning into the show week after week, developing your own method, your own strategy, and your own system for success. So I hope you enjoy these guest episodes. Let's go ahead and get into today's show.
Hello, all you future CRNAs. Welcome to the CRNA School Prep Academy podcast. My name is Rick Heuermann, and I will be your guest host today. And today we're going to talk about how to use your ICU experience to prepare for CRNA school. If this is your first time listening to us, thank you for joining us. If you want to be a CRNA, you're in the right place here with the CRNA School Prep Academy. If you're a returning listener, thank you for continuing to trust us here on your CRNA school journey. A little bit of background on myself for those who haven't seen me on social media or the internet or wherever. Again, my name is Rick Heuermann. I am a third-year SRNA. Prior to attending CRNA school, I always had decent grades in school. I had 3 years as a medical ICU nurse at a large community hospital, a little bit of tele experience as well. And I applied to 2 CRNA schools, and I was fortunate enough to get accepted into both of them. And now I just have 1 semester left of school, and I can see the light at the end of the tunnel. I am done in May, and I couldn't be happier with my decision to pursue CRNA school and be where I am right now. And I'm excited to talk to you today about using your ICU experience to prepare yourself for CRNA school. So as most of you know, if you've pursued the idea of being a CRNA to the point where you're watching this podcast on YouTube or Spotify or wherever, you know that you need ICU experience to be a CRNA. So obviously it's required for everyone, but there's ways that you can use that experience and build that bridge into CRNA school through understanding how your skills in the unit translate to anesthesia. Once you get into school, you will learn everything regardless of how you approach your ICU experience, but making those connections between the ICU and anesthesia might serve you well moving forward and in interviews that have clinical questions involved in them. So ICUs are not all created equal in the eyes of CRNA schools. Some schools even have a point system where if you're in certain ICUs, that's looked upon more favorably in the admissions process. So, for example, CV ICUs and surgical trauma ICUs at level 1 hospitals are considered the most desirable ICUs but others are acceptable. I'm an example. Again, I worked in a medical ICU at a non-trauma center, a large community hospital. We had, I think, 30 beds in our ICU, and it turned into pretty much a COVID ICU during the pandemic. But that's my main background. So regardless of what ICU you work in, what's important in terms of understanding what you're going to be doing as a CRNA is your knowledge of critical care. So what are the 4 aspects of critical care? You have mechanical ventilation, invasive monitoring, use of vasopressors, and taking care of complex patients. So regardless of what ICU you're in, you should be getting exposure to those 4 aspects of critical care. And that's why CRNA schools take students from different ICUs. It's because they have exposure to those 4 things. So we're going to take each one of those 4 things during this episode and break down how you use them in the ICU versus how you're going to use them as a CRNA, so that hopefully in your ICU training, you can visualize how your experience applies to being a CRNA versus just showing up and punching the clock at your ICU shifts. So we're going to start with mechanical ventilation. When you are in the ICU, at least in my ICU, the doctors and the respiratory therapists are the ones in charge of addressing the settings. All I can recall is being on night shift in the ICU and hearing the ventilator alarm and going in there and hitting the 100% button and suctioning the patient and maybe turning up the propofol if I wasn't at the max dose and hoping that the patient wouldn't alarm the ventilator again. Because of course we all know that the ventilators start to sing to each other from across the unit, and it's so much fun. It was so much fun up there in the ICU. So I just remember like in the ICU, I wasn't paying like a lot of attention to the setting because the doctors adjusted the setting. And there's all these different settings: volume control, pressure support when you're weaning the patient off the ventilator, and like all those things I just kind of put off because I wasn't in charge of adjusting the settings. So in anesthesia though, you have to understand those vent modes, because in anesthesia we are the respiratory experts. We decide what vent mode is best for the patient, and different surgeries and different patient comorbidities and things that happen throughout the case will affect how we adjust the vent settings. Sometimes in anesthesia, you're adjusting vent settings several times during a single case, versus up in the ICU, a lot of times they're just left on one setting for a long time up there. So I remember up in the ICU, if the vent keeps alarming and my 3 interventions, 100% propofol and suction, aren't working, I would just call respiratory. And respiratory would show up and hit some buttons, and they'd say, okay, I think it's going to be better now. And I would just say, oh, thank you, and hope it doesn't happen again. But in anesthesia, we have to know how to troubleshoot those alarms. There's high pressure alarms, low pressure alarms, all these other alarms that I didn't even know about as an ICU nurse. But in anesthesia, now I understand all of these alarms and how to troubleshoot them. Because when a patient's under anesthesia, they can desaturate and decompensate from a respiratory perspective super quickly. So we are trained and we learn exactly how to spot what is wrong with a ventilator and how to fix it immediately. So when in anesthesia, when we're deciding the settings and troubleshooting quickly, like we are completely responsible, and it's a huge responsibility, and I didn't even realize it as an ICU nurse. So what can you do in the ICU to prepare yourself for that? Well, I would say pay attention to the setting on the ventilator, like volume control. Try to do some research, ask RT, ask your doctors, what is that? Why are they using that? What's pressure control? Why is pressure support good for weaning the patient off of a ventilator? Those are questions that you can research into yourself and try to make that connection. And also the ventilator alarms, instead of just absentmindedly doing a few interventions, like figure out, why would this ventilator be having a high pressure alarm? Is the tube clogged? Is the tube kinked? Is something wrong with the circuit? Low pressure, is the circuit leaking? Those are things that you can challenge yourself to kind of work through yourself in the ICU as you're collaborating with RT, because those are what you're going to be doing in anesthesia. So just keep those things in the back of your mind. So vent modes, vent alarms, those are the big things that you're going to know inside and out as an anesthesia provider that you don't know as an ICU nurse. Also, extubation criteria. In the ICU, I remember in my ICU there was all this objective extubation criteria that patients had to meet to be extubated. And that is essentially what you're going to be doing in every anesthesia case. There's different types of extubations, like deep and awake extubations. One of the other guest hosts did an episode on this recently. I'd encourage you to go check it out, deep versus awake extubations. But I'm not going to go into that during this episode. But weaning on a ventilator, you do that every single case almost in anesthesia. Like, you intubate the patient, and then most of them are extubated before surgery is over. So you have to know that the patient is ready to be extubated. So I encourage you in your ICU training to pay attention to a patient's readiness to extubate and understanding when they need to remain on the ventilator and when they need to be extubated. So that's mechanical ventilation for you. So you don't need to be a vent expert as an ICU nurse, but just challenge yourself to learn a little more about it, ask questions, and do your own studying if you want to make that experience transfer better to the OR.
Hey there, future CRNA, another dose of daily inspiration along your CRNA journey. So I'm highlighting another community member's success story today. This one is big shout out to Melissa. Congratulations on your acceptance, and thank you so very much for sharing your journey. I found out yesterday that I was accepted into the CRNA program and again, I keep this confidential, class of 2026. I truly could not have done it without the help of Jenny Fennell, Richard Wilson, and CRNA School Prep Academy. They have all proven to be invaluable and will forever be grateful for all the resources and countless hours listening to Jenny and Richard. I'm a part of the low science GPA club, so I didn't think I had a chance of getting in on the first try and doubted myself many times. For anyone applying or thinking about it in the future, believe in yourself and don't give up. And most importantly, join CRNA School Prep Academy. Thank you, Melissa. You're so sweet. And I'm so incredibly proud of you. I wanted to highlight that Melissa didn't have the strongest GPA. She said she was part of the low science GPA club, but she still got in on the first try. So I know I preach that a lot, is to look at your science GPA. However, there are a lot of things you can do to boost your science GPA and prove to these schools that currently you are able to do a graduate level science course and do it successfully, like taking an advanced pathophysiology course, for example. So again, don't let something like fear of having a less than competitive GPA hold you back from applying, because you never know. And really the only way, you guys, to kind of figure out this journey is to just start taking action. So rewards come to action takers. Whether you fail or succeed, either way, you're going to know how to move forward. Okay, so I hope that's a big takeaway for today's episode. And let's get back into today's show.
So the next aspect of critical care is invasive monitoring. So that's your A lines, your PA caths, your central lines. A lines, it's in the ICU, they're put in on a case-by-case basis. Usually patients coming up from certain surgeries that require them, or patients on pressors because of sepsis or other comorbidities. You want to understand, even in the ICU, you want to understand the waveform and what each part of it means and know when it's not accurate. Is it underdampened? Is it overdampened? How do you fix overdampening and underdampening? What's the right height for your transducer? Those are things that I remember that I had to know in the ICU that were important. And the good news is in anesthesia, it's pretty much the exact same. The troubleshooting is especially important because you want to know that you're dealing with an accurate blood pressure and that you're treating an accurate blood pressure. We deal with low blood pressures and high ones very frequently in anesthesia, probably more often than the ICU, and we have to be able to treat them on a dime just immediately. And also in anesthesia, you change positions during procedures a lot, so you need to be conscious of where your A-line is, like the height-wise, the height of the A-line, and you're constantly re-evaluating the accuracy of your waveform. So A-lines, ICU, and anesthesia, pretty much the same concepts apply to what you need to know. PA catheters. So all you CVICU people out there are always dealing with PA catheters. It's pretty cool, cardiac output, PA pressures. The reality is in anesthesia, you are not going to see a lot of PA catheters until your cardiac rotation, or if you take a job that specializes in cardiac. In the ICU, what you can do to prepare yourself for that is take note of normal values and abnormal values and the waveforms and assessing for changes in it, because you need to know if your PA cath is actually in the pulmonary artery. So if you have PA catheter training in the ICU, you have yourself a little bit of a head start for managing these sick hearts and cardiac cases and patients getting non-cardiac surgeries with bad hearts that may need a PA catheter for whatever reason. So CVP with central lines, same thing. You need to know the normal versus the abnormal waveforms and values and just try to understand the waveform, because in anesthesia school, you're going to want to understand the waveform, and you definitely need to know what's a high CVP, what's a low CVP. So if you can gain that experience in the ICU and kind of keep that mentally in your head and take that with you, that's going to be a benefit to you for sure. So we've covered mechanical ventilation, we've covered invasive monitoring. Our next topic is vasopressors, our next aspect of critical care. So in the ICU, from my experience, vasopressors are ordered for us. And at the time they were ordered, it would say like norepinephrine, Levophed, 0.02 to 2 mics per kg per minute. So it would just be a whole range dose for one med, and we would get the power to titrate it. And it was usually titrated to a blood pressure. If a certain dose of norepi wasn't cutting it, then we're looking at adding vasopressin and epi with the same titration parameters. I'm sure you can all relate to this. But so we're just chasing a blood pressure, not exactly knowing every little thing about how the drug works and this and that, but just knowing that we had to stack vasopressors to achieve a certain outcome. Anesthesia, my relationship with drugs as an ICU nurse is a lot different than it is in anesthesia. In the ICU, the drugs are ordered. I know a little bit about them. We give them. In anesthesia, we order the drugs. We decide what drugs to give, what vasopressor to use, what sedatives, everything. So it's a little bit different. So in anesthesia, we assess the patient's situation, their comorbidities, their heart function, and a lot of times, especially their heart function, is going to dictate the best vasopressor for your patient. You decide the drug, you decide the dose. There's no order put in for you. So for example, if we have a patient with an EF of 25% and they have low pressure, blasting phenylephrine or norepi may not be our best option. Maybe some epi and some fluids, maybe a little norepi, I don't know, might be a little bit better. And in anesthesia, we also push vasopressors. I know up in the ICU, it's always infusions. In anesthesia, you're going to learn how to push vasopressors as well as antihypertensives up there. So my word of advice to you, I guess, would be to try to learn the function of those vasopressors and the receptors they work on and the dosing in the ICU. That's going to give you a lot more confidence when you use them in anesthesia. And those are also common interview questions if you get an interview that has a lot of clinical questions. So the last main aspect of critical care that is important to schools and that translates well to anesthesia is complex patients. If you think about it, all those ICU patients you take care of up in the ICUs, patients that are that sick are not generally candidates for regular elective surgeries. So most of the surgeries that you do are going to be on like somewhat healthy patients. So you're not going to be slinging norepi and vaso and epi all the time like you do in the ICU. So your ICU training for those complex patients and those vasopressors is super, super critical. So the more of that you can do, the more code team you can do, the better off you're going to be. Complex patients, your ICU training, a big part of it that translates over to anesthesia is taking care of complex patients with comorbidities. Because in anesthesia, we need to know how each of those comorbidities is going to affect our anesthetic. And we want to be accustomed and tuned into and not intimidated by complex patients when we get them on the operating table in anesthesia. So I remember in the ICU, all these patients would have, they would be septic, they would have COPD, smoking, diabetes, hypertension, asthma, kidney disease, liver disease. It all just like runs together into this label of an ICU patient. And it is the saddest thing, for the patients up there, but it really helps us get tuned in for when we start to become CRNAs and go into anesthesia. In anesthesia, when we look at a list of comorbidities, things should trigger in our brain. That was the way that it was put to me by one of my preceptors. So when I see asthma, that makes me think certain things about anesthesia. When I see high blood pressure, same thing. When I see diabetes, certain things pop into my mind. So like my treatment of different patients under anesthesia is altered based on patients' comorbidities. My anesthesia plan changes. Pharmacology is the same. So patients are on all these different drugs in the ICU, and you see this laundry list of home meds. And it's probably easy to just like skim over these meds and like why they're on them and what they do. It would serve you well to try to learn a little bit about some of those meds. I would especially highlight in the ICU if you can try to dig in a little bit deeper on anticoagulants and on anti-hypoglycemics like diabetic medicines, because those medicines, as well as antihypertensive beta blockers, ACEs, ARBs, medicines like that have a huge impact on how we do anesthesia, the timing of them, and what they do. So, for example, if someone's on Xarelto, we want that patient to be off that for 2 or 3 days before we do surgery on them. That's just one little thing. Is an anticoagulant, and like Eliquis has guidelines. Patients on heparin, that has different guidelines. So like all these different drugs have different impacts on our anesthesia. The new big one is anti-diabetic drug Ozempic. That creates a lot of changes in how we do anesthesia on patients because of the delayed gastric emptying it has. So those are just a couple examples of different drugs. So if you can start to familiarize yourself in the ICU with different drug classes that all these complex patients are on, then you can hopefully translate that over into anesthesia and trigger certain things in your brain when you see a patient on those drugs before you put them to sleep. In summary, the 4 aspects of critical care that are super important that you get in the ICU are mechanical ventilation, invasive monitoring, titration of vasopressors, and taking care of complex patients. My advice to you would be to try to dig into those topics as best you can in the ICU, like a little bit deeper than you need as an ICU nurse, because that's going to help you when you start to get in the OR as a CRNA. Again, in anesthesia school, you do learn all of it, but you can reduce that learning curve for yourself by starting to prepare now. That's pretty much all I have for this episode. That's gonna wrap it up. Please continue to listen to the CRNA School Prep Academy podcast. I encourage you to consider becoming a member of the CRNA School Prep Academy. I've seen their stuff. They have resources, pretty much like a step-by-step A to Z of how to go from being a nurse to being a CRNA. They have different packages that have mentorship options and coaching, and they even have a program that guarantees CRNA school admission if you look into that. So CRNAschoolprepacademy.com, check it out. Like this channel, leave a review, leave a comment, and find us on any streaming platform or video platform that you can. Again, that's going to wrap us up for today. Again, my name is Rick Heuermann. I am your guest host, and hopefully I'll be back for another episode of the CRNA School Prep Academy podcast in the future. Thanks again, and good luck on your journey to becoming CRNAs.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.